Strabismus IC, but if you break it in differently, it becomes Strabis music. So Strabis music is what we are going to have. And in Hindi, I would say, आज चल के तुझे मैं लेके चलूँ एक ऐसे गगन के तले. So that's where we are going to go, where there is happiness and peace for children, so that we spread smiles for children, smiles and stereopsis. So that is the mission that we have. So we have a very good panel of speakers along with me, and we have Dr. Ankur Sinha, Dr. from Jaipur, Dr. Shubhangi Bhave from Nagpur, Dr. Murli from Coimbatore, and Dr. Swati from Delhi itself, AIMS. And I would be starting with this first talk, and we are going to talk about what's new that we are doing in the recent years. Can we have the... So what's new that we are doing, and that's, I will have no financial disclosures. The first thing I would like to say is that we are now switching from cosmesis, personality development, diplopia correction to binocular vision and stereopsis. Our focus or the new goalpost is the stereopsis. That is what we have to focus on. So we are not just treating strabismus, but restoring binocular vision and stereopsis. So in my clinic, the most common used procedure is TNO or stereo testing for each case, pre and post. That's what I would like to do to know how much is the stereopsis and how much we can improve. The critical periods, we have to act early. 6 weeks, we talk about congenital cataracts. So 6 months, we pick up any infantile esotrope or any strabismus problem. And by the first year, we want to correct infantile esotropia. And definitely by 6 years, any intermittent exotropia or nystagmus or refractive error to restore stereopsis. Because it's a timely realignment, even in adults, that's been shown to be maintaining or losing stereopsis. The recipe is observe, confirm, infer, plan, and execute. And as I said, focus on stereopsis. So something new that has been happening in the past few years that changed our practice is from resection of medial rectors. Now we have almost 99% of our cases we are doing plications with a reinforcement suture. So here is the video of a reinforced plication that many of you must be now doing. And here the medial rectus is shown. The conjunctiva is separated and other hook separates it. So here the medial rectus, just like what you do for resection, here the marking is done. These 60 vicryl sutures are imbricated in the muscle. And as we do for resection, we have double or 4 needles or bites to be taken. And now the only difference is we are not going to resect this muscle, but have a passage first muscle, then sclera. So the scleral bite and then again muscle. So it's a MSM, muscle sclera, muscle bite, or a figure of 8 bite. And now you use a iris repositor like a fulcrum and fold the muscle. Neatly it folds when you pull the sutures, and that is what is application of the medial rectus. Very nice procedure which helps us in correcting same way as for resection. And first week post-op, we find that the fullness of plicated medial rectus disappears by end of 1 month. The advantage is early reversibility, which is there with plication. We can easily release. But an interesting thing which I have now found is whenever we say that there are times we are in crisis, we are too old for something and too young for certain other things. Like we say, a girl says that I am too young for dating but too old to leave it. What do you do in between? 30 prisms, 35 prisms of deviations. What do you do? Up to 20 or 25, one lateral rectus recession works very well. But 30-35 is the problem area. More than 35, fine, 2 muscles you can do. But 30-35, I was finding many a time that we want a thing, so I used to release the plication suture. Now I have switched on to doing a 1.5 procedure, what I call as a 1.5 surgery. So lateral rectus recession and a medial rectus central plication. So that works very well. Now this is a mini plication. I think Kenneth Wright was using as a clinic procedure. So what I do is again a reinforced mini plication for the medial rectus. It's much simpler. You have to just take a central bite in the medial rectus, 4 or 4.5 millimeters from the insertion. 60 vicryl suture is passed. 1 bite, remember, just 1 bite. And then we are going to pass in the sclera and then back into the muscle. So this is a reinforcement bite. and again fold it the same way. It neatly folds, and this is just one suture. If at all you have to do, it's just nipping this suture and you can fall back upon. So if there is a surprise you get, you can easily undo that. What happens if you have to shift these muscles? People say that if you have to shift, resection is an easy procedure. Plication, how would you do that? I think, as Dr. Andrea also agrees, we can do plication shifting easily, and that's how we can do it. Like in this case shown you, how we can upshift a plicated muscle. So this is by 5 millimeters upshift. So what we are doing is passing the muscle suture, but here it's a diagonal. Can you notice that? The inferior bite is now taken at the superior edge of the muscle, and this superior bite will be taken 5 millimeters further superior up here in the sclera. So it's a diagonal passage, again muscle, sclera, muscle, and you can then put the suture, the fulcrum, and then tighten the sutures. So it neatly does, and it does the same job as you would see for a resected muscle shifted up. So this is another thing which we have shifted. In DVDs, we all know that 4-week DVDs, we don't do any surgical management. Intermittent DVDs, we may try to convert them into 4-week by optical treatment. For manifest DVDs, those who have associated inferior oblique overaction, the standard procedure is total anterior positioning, right? So like this case, V pattern, inferior oblique overactions are there, DVD is there bilaterally. You do a total anterior positioning of the inferior oblique. It works very well. But if there is no inferior oblique overaction and you do this, there is a problem. It creates an A pattern. And this is what happened in one case done by some colleagues. And then we had to undo this by doing a PTSO on both sides. So what do you do in such cases? We can do an IR plication. Superior rectus recession is also a procedure, but I find IR plication as a much simpler procedure to do for cases without inferior oblique overaction. So if you want to see, it's similar to what we did for medial rectus. But here the IR is being plicated. Again, we take a 4.5 or 5 millimeter bite in the muscle and then bring it on the sclera and then back onto the. So this is again a very neat procedure. The advantage is that you can easily undo a plication. So here you take the marks, and if you want a full effect for more than 10-15 prisms, you take both these bites. If you want only a half effect, then you take a central plication. So even asymmetric DVDs, what I generally do is on one side I do a central plication and the other side I do both these sutures. So it gives me a correction for both DVDs simultaneously. So this is how you can do. In SR recession, we had also done SR recession with Y split in order to enhance the effect of superior rectus weakening. But now I find IR plication serves the purpose, and we rarely do a superior rectus recession or with the Y split. So this is mini plication as advocated by Ken Wright, and this is what we change. So mini plication is very handy if you have a small hypertropia. In DVDs or Heman-Bilchowski's phenomenon, it works very well. Now this child who is having a Heman-Bilchowski's phenomenon, a pre-op, you see that right eye is drifting up. He is having poor vision. So in such a case, you can do a mini plication, it works. So this is what we have been talking about recently. The other thing is myopia. Now in high myopes, we have this strabismus fixus convergence, and what I have changed here is a modified SR-LR loop myopexy for heavy eye for high myopia. The shift is that we don't have to take a scleral bite. You can just do the SR and LR loop myopexy. Now you may say this is similar to what we were doing for Jensen's, and we failed. And I totally discourage people doing Jensen's procedure, because I say that you are passing the vector force of vertical recti through a bad courier. The courier is lateral rectus, which is paralyzed. It cannot transmit the good force. But mind you, in this case, the muscle is not paralyzed. In myopic strabismus, the lateral rectus paralysis is not there. It is the shifted muscle, which is normal otherwise. You can use it to pass the force easily, and it works very well. So you can do a LR-SR loop myopexy without passing into the thin sclera of myopes, which is a problem area. So here, that is another shift which I have done. And many cases which are fresh, we don't have to do MR recession also. If FDT is free, just do LR-SR loop myopexy, and it works very well. So this is what I would like to say is there. And now I would like to call my co-panelist, Dr. Ankur Sinha, who is from Jaipur, a senior consultant, and who has been with us in RP Center AIMS earlier. A very good speaker, and he talks on many things, but here today we are asking him to just talk about sixth nerve palsy management. Dr. Ankur, please come over.
Thank you, Pradeep sir, for a nice introduction. It is always a good feeling to share IIOS with you. And being the mentor, sir has always guided us for many things. And thank you, AIOS, for giving me this opportunity. I'll be talking in brief about the management of sixth nerve palsy. So we all know that the signs symptoms of sixth nerve palsy is a horizontal diplopia which worsens towards the affected size. There can be a face turn to avoid this diplopia. And the measured esotropia would be concomitant, and it will be greater in the action of in the field of action of the muscle. So this is a case of acute onset post-traumatic diplopia. So the patient has a sixth nerve palsy of the right eye, and we can see there's a large hematoma. And what is required in these acute cases post-traumatic is just an observation and follow-up, because sometimes they can recover well. This is another case of 34-year-old males presented with sudden onset of double vision. And there's history of mild headache on and off with occasional vomiting. There is no other neurological illness. And what we see is slight limitation of abduction in both the eyes. So this is a bilateral sixth nerve paresis. Now, whenever we encounter such cases, it is important to dilate the patient, check for all the examination, and we see there's a large papilledema, florid papilledema of both the eyes. So dilated examination is a must whenever we encounter bilateral sixth nerve palsy or an acute sixth nerve palsy in absence of trauma. So this patient has a large intracranial space occupying lesion which was causing this sixth nerve palsy in bilateral eyes. Now, during the acute phase, you can manage with occlusion so as to avoid diplopia, prisms, or Botox. But definitive management is the surgical solution if there is a persistent sixth nerve palsy, and you have to wait for 6 months for the stability of the alignment. So surgical intervention for a partial sixth nerve palsy could be an MR recession, LR resection, or it could be an MR plication, as sir has nicely showed these cases. It could be an RNR or an RNR combined with contralateral MR recession. So this is the case of left post-orbitotomy sixth nerve palsy. We can see a large scar on the left eyebrow, just below the left eyebrow. And this is the, she had a good abduction, so patient went on for a RNR surgery, and this is the good alignment she has post-surgery. So this is the pre and the post photograph of the same patient. Now, for total sixth nerve palsy, we have a lot of options. We can have partial VRT with weakening of MRs, which could be a Botox or recession, or a full tendon VRT with MR weakening procedures, or rectus muscle unions procedures with MR weakening procedures. So there are various reunion procedures like partial VRT as by Hamelsham, or a full tendon VRT with LR cinch by O'Connor. Jampolsky advocated adjustable partial VRT. Then we had options of Jensen's procedure, Kushner's, which was modified with the middle halves. Then all these could lead to strangulation of vessels and maybe a little bit of less than optimum alignment. Rosenbaum talked about full VRT with Botox, and Foster added a Foster's augmentation suture, which we commonly use for most of the surgeries these days. Then we had the Nishida's procedure, which was described with the muscle split initially. Later on, we kind of avoided the muscle split. So what we do is 8 to 10 millimeters from the muscle insertion, 10 to 10 millimeters, 12 millimeters radially midway between the superior and the lateral rectus, inferior and the lateral rectus. We just tie the two muscles together without splitting them. So we can also add MR recession, which could be adjustable. So we can have an adjustable Nishida's procedure, which was again done so by Pradeep Sharma sir. Then we have the left post-traumatic sixth nerve palsy of this patient. We can see there's hardly any movement. So in this patient, what we do is a partial VRT. So this is the half of superior and the half of the inferior rectus, which has been divided and which will be actually shifted to the lateral rectus. That's after the MR. This is the MR recession being done. And post-MR recession, we are going to split the superior and the inferior half of the temporal halves of the lateral and the medial rectus, which will be then tethered to the lateral rectus. And since it was a large angle with absolutely no action of the lateral rectus, we also added the Foster's augmentation suture in this case. So this is the superior part, superior half of the superior rectus, lateral half of the superior rectus, and then we have this augmentation suture. This is the augmentation suture 8 millimeters behind the insertion, which is bringing it close to the lateral rectus. So this is how the direction changes, and this is the inferior part. So we have to be very careful and split the muscles absolutely in the half and split the muscles as far back as possible. again the Foster's suture or the augmentation suture, changing the direction of the muscle towards the lateral rectus. So this is the end of the surgery, and this is the post-surgical alignment. So we have a 9mm recession of the medial rectus along with the half-width transposition. So this is the pre and the post of the same patient. So this is another case with a history of road traffic accident 2 to 3 years back, diplopia in the primary gaze, face turned to the left. So this is a case of right post-traumatic 6th nerve palsy. So what we do here is we do an FDT, we find that everything is clear. So what we do is do a MR recession, which is adjustable. So it's like a hemi-hangback with 1.5 knots, which I usually do. So that we can adjust. There was a good amount of paralysis of the lateral rectus, but there was not tight medial rectus. So this is the hemi-hangback adjustable MR recession. So this is how the MR looks like, so which can be adjusted. And then we do a superior rectus transposed to the lateral rectus. The full width of superior rectus is being transposed to the lateral rectus along with the Foster's suture. So it's just again a 2 muscle surgery, MR recession with the displacement of superior rectus to the lateral rectus with the augmentation suture. So this is the end of the surgery. We did had a little bit of over correction, and then we had to do a little bit of forwarding of the medial rectus, and this was the post-op photograph 1 month post-surgery. So this is the immediate post-op day 1 and the 1 month post-surgery. Another case of post-viral 6th nerve palsy, diplopia in primary gaze with a face turn. We can hardly see any action on the left lateral rectus. So this is again day 1 post-surgery, and this is approximately 5 weeks post-surgery. We can see a good alignment. So in the acute cases, we can do observation if there is no disc edema, especially for children, because most likely they are viral. But if with any evidence of neurological illness, we have to look, get the patient imaged and send it for a neurological consultation. For young adults, look for the risk factors, may have diabetes, blood pressure, giant cell arteritis, they have to be taken care of. Any increasing esotropia or developing neurological signs and symptoms, a detailed evaluation is required, including an imaging. Occlusion can be done to prevent amblyopia in children and to prevent diplopia in adults, also to prevent MR contracture. Prisms can be given for small angles. Then we can also use Botox. This is a case of 6th nerve palsy of the left eye, and this is the post-Botox. After 1 week, there's a good recovery. We're waiting for the LR to come back and get into action so that the eyes can be aligned again. So careful assessment of a 6th nerve palsy is important, and in case of paralytic strabismus, a choice of correct procedure is important in management of these cases. Thank you.
So any question from anybody or any suggestion somebody would like to make? Dr. Andrea, anything you would like to do different? Can you switch on to the other side?
Can you have a mic?
It was a magnificent talk, actually. I don't have anything to add, and I agree. I think most of us already have changed our transpositions procedure to the Nishida procedure, which is a fantastic procedure.
And the other thing which I think one has to take home is these transposition procedures, if done properly, are very strong. So you might think that MR you might require to do anything more than 6. Many a times you don't have to do. It's only as per the tightness of the FDT that you might have to do an MR recession. But as Ankur was showing that he had to advance, and that's what we also found, that we were keeping the MR on an adjustable suture initially. But now we have learned that MR need not be recessed too much. MR has a very little room for recession. So if you go beyond 7.5, you may jeopardize the adduction altogether. Yeah. So as you can just see, we have had a lunch, probably all of you. So on the 6th nerve, we have so many things: the transposition dinner plate, partial tendon VRT, full tendon VRT, single muscle, SRT or IRT. We can augment by resection of the lateral rectus, augmentation by Foster suture. I think Ankur was talking about augmentation by cross-section is what we have talked about, plus antagonist MR recession, plus antagonist MR Botox, and plus antagonist LR plication. So, and of course, the dessert with Nishida has come up, which is very good. Thank you, Ankur, once again. So we have these procedures that are there for us. The modified Nishidas is there.
Can I have a question, please? When you do a full transposition of the superior rectus, what about the vertical, this thing? Does it stay okay? Have you had any problems with the vertical?
No, it doesn't. It doesn't actually cause much of a vertical displacement. So it has never happened. I've done a few cases, and it has never happened that I encountered any vertical kind of squint. Maybe the medial part of the superior rectus, the nasal part, which comes in little more temporally, but it takes care of the elevation. So
No, but you are right. There is a risk of this. And if you see even the published papers from Hunter's group, if you see the pictures, you might see that there is a vertical offshoot. So, and that is why I think there is a very nice suggestion from Federico Velez that if you have a pre-operative hypotropia, you prefer to do an SRT. If you have a pre-operative hypertropia, you do an IRT, inferior rectus transposition. But if you have a normal pre-op, no verticals, then you may do either a partial VRT or a Nishida's procedure. So that is what I would say is, yes, Andrea?
Yeah, may I say something? Because this keeps coming up. It shouldn't be called modified Nishida procedure any longer. In one of the last ISA Strabismus forums, it was clarified by our Japanese colleagues. There was a confusion there because there were two papers, one written by a fellow of Dr. Nishida, but it is the Nishida procedure, not modified Nishida.
Okay. And nowadays they also call it belly transfer. So I think there are people who don't want to give credit to Japanese, probably they say belly transfer, muscle belly transfers. So now we move on to another nerve which creates mischief. That's the third nerve palsy. And there are different strokes in this. The third nerve is a big challenge. I have no financial disclosures again. And as you can see, third nerve supplies all the different muscles that are there in the orbit except for lateral rectus and superior oblique. So it's a big problem. So one is that you have to be careful that you may or may not require surgery. Ischemic third nerve palsies which have a pupil sparing, of course you should wait. And you may, after a month, if it is not recovering, give Botox. But otherwise, just give time and many of these will recover. And as we have seen, like this individual, ischemic third nerve palsy, you see that the pupil sparing is there in the right eye, and he is an elderly person because of which there is a morbidity. And we did a study and we found that many of the people have diabetes, hypertension, which is the most common, and these can have a mononeuropathy, which will usually recover in 6 weeks to 3 months time. But if they don't, or if there is some other cause, then we have to do a surgical management, and you wait for 6 to 9 or 12 months. Now here is the case 1, in which you can see a large angle exotropia, which is there, and he happened to be a doctor, by the way. And what we wanted to do is that we wanted to control also the abduction. We didn't want to lose abduction. So what I did in this LR recession of 24 millimeters. Now here, remember, LRs can be having a long room for recession. If you do small amounts of recession, you will have a problem still. So LRs, you may go up as per the FDT. And in this case, I did 24 millimeters of LR recession and an MR plication of 8 mm. And you see here that the eyes are in the primary position. There is a comfortable abduction also still there. So we are not losing the lateral rectus altogether. So many a times I get cases of operated, which then you have to redo on the LR. So this is one take home. Case 2, split LR transposition. A new addition to our armamentarium is NTSLR, the nasal transposition of split lateral rectus. Okay, a very good procedure. Whenever the FDT for LR is not very, very tight. Mildly tight, you can still do it, but not very tight. If it is very tight, then there will be a problem doing itself and also having other problems. This is another case in which the NTSLR was done, but there was a vertical deviation also, which was very striking. So in such cases, what can you do otherwise? That you can operate on the other contralateral side, vertical recti, to give a correction for the vertical diplopia, which is there along with. Now, third nerve palsy, exo with hypertropia. Now, this sometimes, can we do a nasal transposition of lateral rectus without splitting? Yes. So that's another thing which can be done. You can, lateral rectus can be shifted without splitting inferiorly to correct the forces of exo, as well as also bring the force little downwards. So if there is an hypertropia like in this boy, and I did a nasal transposition of the lateral rectus, full tendon transferred inferiorly, and you can see here that the eyes have also got corrected for the vertical offshoot by just one muscle. So one muscle shifting can do the trick. You may have to put a Foster suture in order to get the lateral rectus little close to the medial rectus. Very tight lateral rectus, what do? You can do a periosteal anchoring of the lateral rectus. So here it is a lateral rectus which is very, very tight. You want to take away altogether its force, then anchoring of that can be done, which was demonstrated by Velez and Jepos 2004. And this is a good procedure which can be used selectively. But very exo of 90 to 100 prisms, what do? After the lateral rectus has been stripped of all its function, still the eye is exo. That case you can do a periosteal anchoring of the globe medially. So this is another procedure which can be done in these cases, and we have talked about doing through the DCR skin approach as well as the pre-caruncular or retrocaruncular approach. Aberrant regeneration, what do? If you have an aberrant regeneration of the lid, then what can we do? Sometimes, like in this case, what do you see here? In the primary position, the eyes are ortho. The only problem here is with the lid. So this case came with the problem of lid. You have to counsel them that, look here, I am not required. I might be requiring an oculoplasty surgeon, but he also may not dare to do in the presence of a third nerve palsy anything, and only a suspension sometimes, or maybe just a spectacle with a crutch glass may be given. So here you need to just counsel. But sometimes we find that there is a correction by the contralateral eye being operated. Like in this case, the left eye is third nerve palsy exo. I operated on the right eye, the recess resect with the fixation duress approach, and you find here that these also can be a very good approach to correct. Like this case, you see here the eyes are ortho in primary position. The lid which was having ptosis has also got corrected because of the fixation duress getting the innervation to the LPS. What do you do in cases of acquired partial third nerve if there is an inferior division alone which has been involved? Now you find these cases having exo with an hypertropia. So one possibility is, of course, you can shift the lateral rectus full width nasally, or what else you can do is an inverse nap procedure. Now what we mean by inverse nap here is modified inverse nap. Now what I mean here is that you want to have a downward force as well as weaken the lateral rectus. So if you do a lateral rectus weakening and then shift it, it's not going to work as good, because you are asking the lateral rectus to work as well as weaken it. That is something which is a paradox. So what I do is lateral rectus is shifted as it is. The exo is corrected by the medial rectus, which is resected and shifted. So that is a modified inverse snap. That you resect the medial rectus, you strengthen the medial rectus, which will also give you a downward force as well as give you an adduction force, and the lateral rectus is weakened. Unless the FDT is still tight, you don't want to recess the LR. So that is something which can be done, like in this case, this girl who was an aspirant medical student, and she's very happy with this, that she's having a correction. Sometimes you have a lateral incompetence in the other eye, and in such cases I have operated on the other eye lateral rectus, a Scott procedure. That means you want to weaken. Why? If you see here in the gazes, 8 prism basin, there is a 16 prism basin in the primary position and 35 prism basin in the adduction. So what do? How can you improve it further? You can, if you weaken the lateral rectus such a way that you have more of weakening on the abduction, you can do a Scott procedure on the lateral rectus, because Farden doesn't work well on the lateral rectus. So what you do, alternative to Farden is a Scott procedure on the lateral rectus. It works very good, and you can try this doing it. So here, this is what we did in this lady, and we found that the abduction was more neatly controlled, and this is published in JPOS. A re-surgery, sometimes these cases come up because the lateral rectus has not been recessed enough. So you have to explore it, do an LR recession. So I happen to do 25 millimeters of re-recession then finally, and with an IR belly transfer to the medial rectus. So just half of Nishida or belly transfer of the inferior rectus alone was done in this case, and that has got corrected. Again, he was a medical doctor, and we had to be a little more concerned that he retains his binocular vision. So important points to remember in third nerve palsy is deviation in the primary position and other gazes have to be taken into account. Fixing eye is the target deviation. Look for the incompetence. The realistic goal has to be told to the patient. You may not be able to correct all the 9 gazes. We try to correct the primary and maybe a little bit of hypo. That is what may be the only thing which may be correctable. and you do the FDT of the LR, supramaximal recessions, periosteal fixation or split LR to MR, these are the options, or also a contralateral muscle surgery. Either the horizontal recti for the LPS action, or sometimes the vertical recti on the opposite muscles can be done. So you have to be a squintellectual, and to carry on with other squintellectuals which are there, luckily with me, I have Dr. Shubhangi Bhave, who is coming from Nagpur, and we are lucky to have her. She is also the president of SPOCI, or the SSI. So she is a senior consultant, Strabismus, in Nagpur, and I would request her to be talking us how we manage the fourth nerve palsies. Switch on to the other side. The fourth nerve palsies, she'll say.
A very good afternoon to everyone, and thanks, sir, for that wonderful introduction. It's an honor to be a part of your instruction course. Where is my-
Patients in which you have done a fellow eye surgery to take advantage of the aberrant regeneration, if there is a residual hypotropia in the involved eye, like a right third nerve palsy, you have done a left eye recess resect, you have restored the horizontal alignment in primary position, but there is a persistent right eye hypotropia. What are your options? So would you do a superior rectus plication in the involved eye, or does a lateral to superior rectus transposition?
So if you had it already, then you could have done in the first sitting, if you have, like I showed you, you can do a modification of the NAP procedure.
Yeah.
Then you can do that you can have the vertical offsets to correct that pre-existing vertical deviation. If you discovered it later on, then you may choose to do a plication accordingly. If suppose there is a hypertropia, you may do an IR plication, or if you have a hypotropia, then you can do an SR plication.
But if the SR, let us say, doesn't have any residual function, will a...
No, in the other eye you're doing, no?
Okay.
You can do the other eye, I'm saying. So like one case had shown, we did the contralateral other eye to correct the vertical deviation which was large.
But the other eye, in the recess resect muscle, that
Yeah,
is
you
the
can do a
horizontal-
third muscle plication.
Oh, third muscle plication can
Third muscle plication. So taking care that the vessels are spared.
spared. Okay.
So you have to be careful, because inferior rectus is the major supplier of blood vessel. So you have to be very careful of the blood vessels, and then you can do a plication. If it is about only 10 prisms, a central mini plication saving the vessels is going to be effective.
But will a lateral rectus transfer upwards in the involved eye, because the lateral rectus still has some residual function? Does it help in any way, sir?
No, you're talking of the lateral rectus
In the involved eye.
in the involved eye. We have already done, you said, no?
No. In the
Achha,
fellow
only
eye
the-
we have done for the aberrant regeneration. Ptosis is corrected. The horizontal alignment is good, but still there is a residual hypotropia with no nil superior rectus function.
Yeah. So if there is no function of vertical recti in the involved eye, then probably you can do what I'm saying, the other eye plication. But if you have some function, sometimes there is, then you may do still vertical muscles, you can do that.
Okay,
You
but
can
the
try
lateral
that.
rectus upward shift in the involved eye doesn't help.
I haven't tried that. Dr. Andrea, anything?
If you have done a recess resect in the fellow eye to take advantage of the aberrant regeneration, and now the horizontal alignment is corrected, but you have a residual hypotropia in the involved eye. So the lateral rectus in the involved eye still has some function. So will a transposition of the lateral to the superior rectus in the involved eye, will it help correct the hypotropia?
No, I think that would be too much unpredictable. I would prefer to address this by touching a mini plication in the hypertrophic eye in order to compensate.
Right. So thank you, Dr. Andrea. Now we come to Dr. Shubhangi.
Yeah.
So supraoblique palsies, please.
Yeah, thanks a lot, sir, and I thank AIOS for asking me to be part of this IC. The superior oblique palsy is the most common cyclovertical muscle palsy which is encountered by an ophthalmologist. It could be congenital or acquired. Congenital are usually unilateral. One has to watch for contralateral hypoplasia. There's either defect in the nucleus or motor portion of the fourth nerve. and acquired is generally bilateral. It could form, it could be due to closed head trauma or the ischemic problems. There is an entity called as masked bilateral superior oblique palsy, where the palsy is more manifest in one eye and the other eye remains latent, and we have to identify it by the presence of V phenomena or head tilts. Otherwise, when we operate one eye, the other eye palsy will become manifest. So the diagnosis is done by measurement of ocular deviations in all the 9, basically a clinical diagnosis. All 9 diagnostic positions, right and left head tilt is important for diagnosing and planning treatment. Versions should be examined. Antagonists like infraoblique, infrarectus, superrectus in the involved eye should be examined. Park's 3-step test is important, though in about 50 to 70% of cases only it is applicable, or the sensitivity is 50 to 70%. Hess and diplopia charting and fundus evaluation for torsion are the things we look for. So, in cases of congenital palsy, it is more commonly a floppy tendon. So, primarily we shorten or tighten the superior oblique tendon, whereas in acquired superior oblique, the most common procedure is recessing the opposing muscle, that is the inferior oblique recession. If the vertical deviation is more than 15 prism diopters, we consider the recession of contralateral inferior rectus. If long-standing and the eye has poor depression, superior rectus is likely to be contracted and might require a recession. If X-cyclotorsion is significant, then Harada-Ito's procedure. So this is the video of exaggerated force junction test. We need to dip the eyeball into the orbit and then move the eyeball in the direction of supraoblique, so that we know whether there is a laxity of the tendon or tightness of the tendon, and many of our management strategies are based on how lax the tendon is. Now, coming to this case of congenital fourth nerve palsy, you can see a significant facial asymmetry. The patient had an R by L which was more in left gaze and right head tilt. There was about 25 prism diopters of R by L with 30 prism diopters of, he had an esotropia also in the primary position, and the R by L increased to 30 in the left gaze. There was a V ESO and there was evidence of torsion in both the eyes. Now this is how the R by L readings in the 9 gazes, which was more in the levo version gazes, suggesting that right SO was more palsied. And this is the post-op picture after doing R&R in the right eye, right infraoblique recession with right supraoblique tuck, and the left inferior oblique recession. The V was reduced and the horizontal deviation was corrected. Now, superior oblique tuck is done in cases of superior oblique palsy, and I do it at the medial border of superior rectus muscle. We can do up to 22 millimeters of tuck. Non-absorbable sutures are used to suture the tuck, and I generally leave the apex unsutured. And at the end of the surgery, one should do an FDT to see that it is, the eyeball is going beneath the midline, so as we're not creating a acquired browns. So this is how the surgery goes. Then the surgical techniques, the other surgical techniques which we do are the infraoblique recession, which is the most common, Harada-Ito, contralateral IR recession and SR recession. There's a NAPS classification which tells us which muscle to be done when the deviation is more on which side. So I'm not going in the details. I think this is infraoblique recession video. This we can skip. And this is another patient who had a small acquired superior oblique palsy. He had a small L by R in the primary position, which increased to the maximum in dextrodepression. He had maximum L by R in dextrodepression, and so we just did his right inferior rectus recession, which corrected his head posture and diplopia. And this was the HES chart, the pre-op HES chart, which is again showing maximum deviation in dextrodepression, which was corrected after doing the, yes. Now this was a case of traumatic right superior oblique palsy. She had an exodeviation with hypertropia R by L, and she had about 10 degree of excyclotorsion. So these are the post-op images after doing the recession of lateral rectus, inferior oblique recession with Harada-Ito to right superior oblique. Now these are the pre-op HES chart, which is showing the excyclotorsion under action of right superior oblique and other changes, which is corrected post-operatively after the surgery. She was diplopia free after the surgery. This is the Harada-Ito. We know that the anterior 1/3 of the superior oblique muscle is responsible for intorsion, and the posterior 2/3 are responsible for depression. Here the anterior 1/3 fibers are separated, and they are then sutured to about 8 millimeters above the superior border of lateral rectus. METS has even proposed an adjustable type of Harada-Ito, which I have not done. And thanks for the patient listening.
Thank you, Shubhangi, for keeping it very, very short and sweet. So we have time for any questions,
Yeah.
anything? Anyone wants to ask or suggest something which he or she does differently? Can you switch on to this side? So, as we have learned from Dr. Shubhangi, that the most common muscle in supraoblique palsies to be tackled is inferior oblique. I would like to again stress something which I keep on doing. Don't do myectomies. Don't do inferior oblique myectomy. Do a controlled inferior oblique recession. That is why, because squint comes just like you have in different shapes and sizes. You have to do, and when you go to the mall, you have a choice of choosing your right size. In myectomy, there is nothing like that. It's just cut and shoot, go. And these cases, when they come back to me for a follow-up and for some further correction, I have a great problem. So now I've become more and more stronger proponent of letting people not do myectomies. So, and there are some people who still do. I would like to say that don't do myectomies. You have a very good option of doing various procedures on inferior oblique weakening.
Just one comment, sir.
Yes, sir.
Normally it's written in the books that when the deviation is more than 25, we do 2 muscle, but then we have to also be careful in doing 2 muscles for that deviation, because sometimes if the symptoms are less, it is always better to do a staged approach, because overcorrections are also common after doing 2 muscles, especially if you're doing inferior rectus recession along with inferior oblique recession.
So you should know, because here, as again and again we are saying, we have to be targeting binocular vision and stereopsis. Don't chew more than what you can, don't bite more than what you can chew. So here it's the same thing. But if you're sure, you have to do 2 muscles, you may do in the same sitting, but many times you have to do a graded approach. So inferior obliques, in the meantime, we'll be requesting now the next speaker, Dr. Muralidhar, as he sets up his stage. Inka setup kar dena. So inferior obliques, we have different procedures, and with the addition of the stages procedure of anterior nasal transpositioning, even the 3+, 4+ overactions can be corrected. So inferior oblique recession, you can do a very graded approach. You can do a total anteropositioning, which I reserve for DVD cases with inferior oblique overaction. It gives me the anti-elevation, which is the desired thing in such cases. But otherwise, I avoid. And I do if there is a bilateral inferior oblique overaction, you can do in such cases an AP. But if you want a 3+, 4+ overaction, and many a times we have overactions of these, like severe IOA is there in this case. You have to do a antenasal transpositioning. Anybody would like to see the video of antenasal transpositioning? Okay, so we can just go in this. It's a short video. How we do the infero-oblique anteronasal transpositioning from the inferotemporal approach, fornix incision. The lateral rectus is hooked, and the infero-oblique. So this is the standard thing for all infero-oblique procedures. This approach inferotemporal, and you neatly get the infero-oblique in your hook. See the white triangle beneath, ensuring that all the fibers are in your hook, and then you split the intramuscular septum behind it, and then you can disinsert the infero-oblique. Don't have to pass sutures at this stage. You can pass it. The infero-oblique never gets lost. You don't have to struggle to pass sutures before disinserting the infero-oblique. So once you have disinserted, then you pass the sutures, the 6-0 Weichel sutures, and now you have a choice. Depending upon what you want to do, you can do either a Fink's recession, a Park's recession, you can do a total anteropositioning, or you can do an antenasal trans. Now this is the difference. Now IR is being hooked, first with the Jamieson's hook, then Green's hook. Now this is the inferior rectus being uncovered, and from the temporal you start seeing now the nasal side of the inferior rectus. Cut the intramuscular septum, and you see the sclera nasally, and 2 millimeters. Now you are getting the infero-oblique coming down inferior to the inferior rectus. Separate these intramuscular septum and the attachments to the Lockwood ligament, and then you will see here that pass it 2 millimeters from the nasal side of the inferior rectus and 2 millimeters from the insertion posteriorly. If you pass this way, then you don't have an anti-elevation. If you want an anti-elevation effect, you can bring it more and more anterior. So sometimes you want an anti-elevation effect, like there is a differential infero-oblique overaction, then you can choose to do that. Otherwise, this is a very simple procedure of infero-oblique weakening, and you don't have to do a myectomy. So that is what I would like to say. Don't do the myectomy, just do simple things. And now we have from South, one of my residents earlier, and now a person whom I feel very proud to be always calling in my talks. He does wonderful job there in Coimbatore, and I think Muralidhar is going to talk today on congenital fibrosis of extraocular muscles. One of the most difficult subjects in strabismus is managing CFUMs, and that's why I chose to pass it on to him. So,
thank you, sir. It's always a pride and pleasure to be your student as well as to be in your IC. Thank you so much for having me here, sir. So I'll be talking on the management of congenital fibrosis of the extraocular muscles. So congenital fibrosis of the extraocular muscle is a hereditary non-progressive disease causing restrictive ophthalmoplegia. It's a subset of the congenital cranial disinnervation or congenital innervation disorders. So ptosis is a variable component often present, characterized by poor bells. Initially, it was thought that the primary pathology was fibrosis of the extraocular muscle. Later on, now we know through detailed MRI studies that it is hypoplasia or aplasia of the third and fourth nerve nucleus, and EOM atrophy is a secondary cause. A total of 7 genes have been identified. So just to summarize this busy table, we have 5 main types of CFEOM. So CFEOM 1 is characterized by large exo and hypotropia, large exo and hypotropia, and the most commonly involved gene is SCIF21A. CFEOM2 is characterized by a large angle exotropia. In CFEOM1, it was a large hypo and exo. CFEOM2, it's a large angle exotropia with pupillary involvement. CFEOM3 is marked by asymmetry, and CFEOM4 is called Tuchel syndrome, and CFEOM3 plus oligodactyly, and CFEOM5 is synergistic divergence. So it may have a number of systemic and ocular associations. Among the ocular associations, infantile nystagmus syndrome, optic nerve hypoplasia, retinal dysfunction predominate. And in systemic associations, you can have Joubert syndrome, you can have Prader-Willi, which has diabetes mellitus, and you can have arthrogryposis. So you have to look for all of these. So the MRI findings is characterized by, this I have taken from an article, and absence of cranial nerve, third and sixth have been demonstrated in majority of cases. The EOM atrophy to a certain extent correlates, but the clinical picture does not. So if you have a congenital absence of third and sixth nerve, either on one on both sides, so that was how it was worked out that the primary pathology is hypoplasia or aplasia of the third and sixth nerve nucleus. So this is the hallmark of CFEOM1.
which is a substitute convergence on attempted elevation. So when the patient tries to look up, you have a substitute convergence. So you may have associated ptosis. The first patient did not have a good amount of ptosis, but here you can see that the patient has ptosis. When the patient tries to look down, the globes tend to diverge out. When the patient tries to look up, you have a substitute convergence. So because the globes would not rise above the midline, these patients often have a chin elevation, and they develop a number of head postures to compensate for the lack of elevation. So CFUM1 is characterized by autosomal dominant inheritance. So you see at the top the father and the daughter, both of them having a congenital fibrosis of the extraocular muscle. So this is a patient with bilateral ptosis, and this is how she has adjusted to use both her fingers to lift the lids when you ask her to read. I have a short video. I've gotten the consent for this. So when you ask the patient to read the letter chart, first she tries to avoid, but this is how she adapts to read this. So this is what we want to correct. So the management, of course, is as for any other strabismus, the preliminary management. You have to take care of refractive errors. You have to take care of the amblyopia management. And surgery is required when you want to clear the visual axis because of a ptosis or because of severe hypotropia, to alleviate the head posture and to correct the primary position alignment as far as possible, in addition to supportive measures like lubricants, the importance of which cannot be understated. So the challenges are, one is that the FDT is variable. Even though the term is congenital fibrosis, the force reduction is not always positive. So hypotropia is the major thing that you have to correct. So you need a large inferior rectus recession, 6 to 12 millimeter, and anterior segment ischemia is a very important consideration in these patients. Sometimes they may have lesser number of ciliary vessels, and even one muscle surgery may trigger an anterior segment ischemia. They may have fibrotic bands posteriorly, so you need to do a real posterior dissection. For ptosis, you can use either crutch classes or frontalis sling along with a lot of lubrication. So this was a patient with global ophthalmoplegia and congenital restriction of all extraocular movements. So please note, resection is controversial. So wherever you ask him to look, he is unable to look anywhere. The problem was that in the left eye, he had a large esotropia, which was his better seeing eye, with a vision of 6/9. And in the right eye, it was amblyopic because patient had a high myopia. So this was a patient with what is called a Varadi-Papp syndrome. He had oligodactyly, and he also had cryptorchidism, and he also had pituitary insufficiency and growth hormone deficiency. So what we did here was we did a recession of the medial rectus, and I also plicated the lateral rectus. So the hypotropia still is there. But he had 1+ cells on the first postoperative day, even though I had done lateral rectus plication. So I really did not dare to do a third muscle. He also developed another complication, so which is a surgically induced necrotizing scleritis. I had also tackled the superior oblique. In addition to the recess resect, I had done a Burke stenotomy of the superior oblique. So he developed this, and not very keen to give him steroids. A systemic workup for any associated rheumatologic disorder turned out negative. So we managed him conservatively with topical reconstituted and N-acetylcysteine eye drops. We also published this, and so eventually the sclera vascularized and he recovered. So this was another interesting patient. So it was a family, both the father, the daughter, and the son. The daughter consented to undergo surgery first. She has a synergistic convergence and on attempted upgaze. So we did a bilateral inferior rectus recession of 10 millimeter with a nasal shifting, so you don't induce a pattern, along with superior oblique tenotomy. So we got the right eye to elevate a little bit. The left eye did not budge at all. So you'll see that the synergistic convergence has gone away, and the ptosis was managed with crutch classes. We got her got a satisfactory improvement in head posture, which she was happy with. And so then you have a CCDD with synergistic downshoot, the management of which I learned from Sharma sir. So you deactivate the lateral rectus, and then you transpose the IR to MR. So this was a patient with a synergistic downshoot. So you can see the preoperative video. So as you ask the patient to look out, the right eye just shoots down. So here what you have to do is you have to deactivate the lateral rectus to take care of the exotropia, and an inferior rectus shifting to the medial rectus. The inferior rectus was so tight that I had to use non-absorbable sutures to get it through. So the inferior rectus was disinserted and with non-absorbable 50 ethibond sutures, and it was transposed adjacent to the medial rectus. So it was so tight, I wasn't very keen to use absorbable sutures. I had used non-absorbable sutures. In spite of that, the patient still continued to have some synergistic downshoot, though it was much better than what it was before. So in spite of that, the patient still continues to have an exo. I would say the downshoot is somewhat better. It really didn't go so much, at least in primary position. If you see primary position, this was the primary position where the globe is so much hypotropic. But at least in primary position, the globe has come up a little bit. So for all that we did, the downshoot is improved. And this is a patient with CFEOM type 5 with the splits, what we call the splits. So it is a so here the treatment is to do a lateral rectus deactivation. So we have done a lateral rectus deactivation, and yeah, I'm summarizing this thing. So you still have a synergistic downshoot, but this was a very old patient, and I learnt about this inferior rectus transposition much later on from sir's presentation. So if you are not very encouraged to do the surgeries, I have presented a summary of the outcome. In general, in 35 to 40%, you get a good improvement in head posture. In another 30, you get a fair improvement. This is a patient with a unilateral fibrosis. He wanted to know if something can be done for the enophthalmos. The CT scan had been done outside. So if you note here, the muscles are paper thin. So this is what you get in imaging. All of these patients need orbital imaging to see if any extraocular muscles may be absent or are they present to get any get an idea of change in course or change in insertions. So thank you so much for.
Thank you, Murli. I think that was an excellent presentation for a very complicated subject, that's CFUM. It presents in various ways. Each case is to be handled differently. And we may have to do IR recessions, LR recessions, sometimes superior obliques also have to be managed, and we have it. So that is right. Nowadays for synergistic divergence, I would say the ideal procedure is NTSLR. Synergistic divergence. So synergistic innervational downshoot, yes. IR shifted to the MR is the right thing. You are doing a targeted strabismus surgery, as I say. It is the inferior rectus is getting innervation during adduction. So put it there. So it's like a child who is always trying to work on some other place, put him there. He's also happy to work there and our job is served. But if it's a synergistic divergence, what is happening is that the lateral rectus is firing during adduction. So in this case, what we want to do is NTSLR. So ideal procedure for NTSLR is synergistic divergence. That you always get the lateral rectus to the nasal side, and these children are most happy because they get the adduction, which is at the right time. So I think that is the ideal procedure, I would say. So thank you, Murli. He also touched about an interesting thing, that is the SINS. So the strabismus induced necrotizing scleritis. Anybody has encountered? Yeah. So unfortunately, yes, even I had a case which was an infantile esotrope. An MR recession I had done on both the eyes, and one eye was okay, the other eye went into a SINS. So it is a terrible thing, a child having that, and what to do. And it was suddenly, I mean, after 1 week, she comes with melting of the sclera and the cornea. So we had to give steroids in such cases. It's an autoimmune response. So you have to give steroids, systemic steroids, and then also did a sclerocorneal graft. Fortunately, we got back 6/6 vision and good convergence. So that is something which is, I mean, it's the, our sins being coming back to catch us. So thank you, Murli. Now I move on to another complex subject, and that is solving the enigma of DRS, the Duane's retraction syndrome. So Duane's retraction syndrome, as you see, is one of the most common CCDD, the congenital cranial degeneration disorder, which is because of the sixth nerve aplasia to start with. And it was initially described by Hewitt and Stilling and then Duane's. It is 1 to 4% of strabismus patients. There is a surprising female preponderance of about 60% and unilateral cases more of left predominance. The interesting part I learned from Parsa's article why this is happening. That's something which I would like to always say. So in this, what is happening is there is an innervational problem. Primary disinnervation is lateral rectus not getting innervation during abduction. Secondary disinnervation is that the lateral rectus is getting innervation during adduction or at both times. Okay. So ESO-DRS are cases in which the lateral rectus doesn't fire during abduction but starts having innervation during adduction, and classically you see them as ESO-DRS in primary position with marked upshoot, downshoot, retraction and narrowing in adduction. On the other hand, the exo-DRS cases are exo in primary position, but a similar picture in adduction, and they may have sometimes normal abduction, sometimes they also have limited abduction. So each case has to be seen differently. So these studies of the, if you see the MRIs, you will see them that there is a missing nerve, sixth nerve or the pons. And as we can explain the paradoxic innervation, we need to tackle it in the same manner. Also remember, there are associated ocular problems which are there. The one common thing which we usually used to miss, but I think thanks to Marilyn Miller, I always ask the question about crocodile tears. And this is something you'll find in many cases when the mother will say, oh yes, whenever he eats biscuits or anything, he tears, his eyes are tearing. So this is the abnormal gastro-lacrimal reflex which happens. A Marcus gun jaw winking is another common thing which you may come across. So Duane's retraction syndrome systemic associations are also there. So ask about these. And the syndromes which are associated like golden Haar, Klippel-Feil, Wildervank, Holt-Oram, Okihiro, or the IVIC syndromes. So these are associated things which you will have to keep in mind whenever you have the case of DRS. Ask about these, like here the neck is short neck and there is a Marcus gun jaw winking, deafness is there in many of these. In Holt-Oram again cardiac anomalies may be there along with the morning glory. The embryogenesis is interesting. Around 4 to 8 weeks of embryogenesis. Again, thanks to Marilyn Miller, we learned about this. Thalidomide and misoprostol is one of the culprits in some of the cases. It's the higher estrogen level and inflammation which causes venous thromboembolic events. I think an interesting article by Parsa and Robert in JAMA Ophthalmology 2013 is there, which I like because it suggests that if we can control thrombogenic influences during the first trimester in these pregnant ladies, we may be able to probably prevent having Duane's retraction syndrome in future. So genetics counseling, yes, there may be some cases, about 20% which may have genetic disorders associated, gene review may be done. How do we manage in this surgically? What I say is that follow first of all whether it's an ESO, EXO or ortho. Second, look for the co-contraction. By rule, co-contraction is always there. See whether it is significant, mild or very severe. How much is the normal LR activity? Now this is particularly seen in exo-DRS cases. It will change our management. And finally, force reduction test both for MR and LR. So these are the 4 points which I have sort of taken the gist out of a wonderful article in Rosenbaum's book by the great Jampolsky. And in that chapter will take many months to read and understand. But if you can summarize, I think this is 4 points which I got. These have to be kept in mind. So if you have a case in which there is a ESO-DRS in the primary position, the FDT MR is positive and minimal co-contraction is there, you need to do an LMR recession for just the tightness of the MR. Minimal MR recession is what we need to do, and that does the job. If you do more MR recession, you will land up into a iatrogenic synergistic divergence. Because there is a co-contraction, you have weakened the medial rectus force, the lateral rectus is now uncontrolled and it causes an exo whenever the person is looking on adduction. So this is something you have to be aware of. Again, that figure is from Jampolsky's chapter. So what we do in such cases, whenever there is a moderate to severe co-contraction, always balance the lateral rectus with a split LR and recession. A Y split LR with recession. A split should be at least 22 millimeters from between the two ends. So in ESO-DRS, what you do is this, that you will do a MR recession along with a split LR recession with that. I think there are some articles, especially I think from Canadian group, that you may do a little bit of resection by, generally we say don't do LR resections in DRS cases. But I think there are some reports, but I think you have to read between the lines. What he has said is never do more than 3 to 4 millimeters of resection. Very small amounts of LR resection he has talked about for ESO-DRS. So in ESO-DRS, when there is FDT is not there for MR, you may do only the SRT, and that may be just enough for improving the abduction as well as correcting the ESO. So this is the planning algorithm for ESO-DRS. For exo-DRS, our strategies will depend on how much is the exotropia, how much is the co-contraction, how much is the LR activity, whether it is normal or it is missing. Now, if there is some LR activity, you don't want to sacrifice the lateral rectus. So you do an LR recession with Y split, and many a times 12, 14 or up to 20, 30 prisms of exo will be just corrected by single muscle surgery, LR recession with the Y split. LR recession will depend upon the exo in the primary position and the retraction, and the split is going to take care of the upshoots and downshoots. Remember, it's the recession which is taking care of retraction, not the split. The split is only taking care of upshoots and downshoots. So this is a procedure of LR recession with Y split in exo-DRS cases. Little is no good for exo-DRS. I think this is again one point which Japolsky talks about, that he says that you may have to do for each prism 1 millimeter of LR recession. So you have to be very careful in how much recession you do, and sometimes we have to do a periosteal fixation of LR along with the partial VRT to improve the abduction. I don't want to go into this detail of the video. You can see on the net, this is available. Adjustable partial VRT, or nowadays the Nishida procedure is very handy that we do. So you can, now this guy we did a partial VRT, and you see the abduction is improved along with the exo-DRS getting corrected in the right eye. But here we have done a modified Nishida to improve the abduction, and this is something which now has been promoted by some people as the double K Kushner and I think procedure. So plus modified Nishidas and LR recession with Y split can be done. So the exo-DRS planning algorithm is this, that you will depend upon the LR activity, how much and what to do. Ortho-DRS are more difficult to handle because they have a challenge to be maintained, that ortho is to be maintained in primary position, and still you want to correct the problem in the adduction. You have to do an MR recession on an adjustable suture and LR recession with Y split. So this is what is the take home in the DRS cases. ESO-DRS, MR recession alone, or MR recession with LR recession with Y split, depending upon the severity of co-contraction. Exo-DRS cases, large LR recession along with a Y split, or if there is a no LR activity, then you can do a periosteal fixation for very severe exo-DRS cases. And abduction you can improve by partial VRT. Ortho-DRS cases, do an adjustable MR and LR recession with Y split. And to improve abduction, which can only be done if the LR paradoxic activity has been already taken into account. The risk of ASI should be kept in mind. Don't want to handle the vertical recti in the presence of both MR and LR already being handled. So that is something which we would like to remember in DRS cases. Before we have, I think, time for discussion, we have one more talk, and that is to talk about Brown syndrome management. And I will invite Dr. Swati, who is Professor of Strabismus Neuro-Ophthalmology at my alma mater, RPC AIMS. So we have Dr. Swati. Yes, in the meantime, she sets up the thing. You can, yeah,
So
please.
what about doing LR recession in the other eye? If there's a large exo and you've already recessed, not periosteal fixation, you've already recessed the LR with a Y split. Do you touch?
So you can do, suppose there is a very large LR recession and you did not do enough LR initially, and you cannot do now, suppose it's been done like 14 mm, and now to retrieve that 14 mm and do more is sometimes more difficult. Then like in one of the cases we had done the LR on the other side. So you can do an LR recession on the normal side in exo-DRS cases for the leftover exo. Quite right. Yes, yes, Jasprit. Can somebody give the mic, or you can come forward, Jasprit? By the way, congratulations, Jasprit, for your FICO.
Thank you, sir. Thank you so much. So for the large recession, like 14, 20 millimeters, do you do a direct anchoring, or do you need partial hangback, or how do you do it?
I think wonderful question. So what I do is that I do a hemi hangback.
Yeah.
So I never want to hang back more than 7 mm because it may creep forward. So what I do is, like, if I have to do 24 mm, I would be passing the sutures at 17 or 18 mm on the sclera, and 6 or 7 I would let it hang back. Yes, I think, do we have Swati's? Yes.
Yeah, thank you, sir, for this opportunity. It's always an honor to share the desk with you. Thank you, sir. So I would be talking about Brown syndrome. It is also a kind of CCD, just like CFAM and DRS, and it is characterized by inability to elevate the eye in adducted position, both actively as well as passively. That means that there is a tight superior oblique there. So this you can see there is deficient elevation in adduction. There is unaffected elevation in straight up gaze or in abduction. So this is a characteristic of Brown's, and you will have a Y pattern divergence in up gaze. So all these features definitely point towards the Brown syndrome. The differential diagnosis that we need to consider is a true inferior oblique palsy, which can be differentiated by A pattern, presence of A pattern and head tilt test. And on doing FDT, the superior oblique may not be tight. Another thing that we need to differentiate it from is primary superior oblique overaction, which again will present as an A pattern exotropia in down gaze. It needs to be differentiated from monocular elevation deficit, which is the limitation of elevation in abduction, not in adduction, and also the blowout fracture, where we have entrapment of IR muscle, which will also present as an elevation deficit. So all these things need to be differentiated from Brown's, and it's not so difficult if you do a proper clinical examination. So as I said, there is a divergence in upgaze, there is a normal elevation in abduction, and the FDT is tight. It can be graded as mild, moderate, severe, depending on the presence of limitation of the elevation in adduction, and also it presence of the superior oblique overaction. So the presence of superior oblique overaction is known as Brown plus. The pathophysiology, it is a congenital syndrome, and the primary pathology remains there in the tendon of superior oblique. So the tendon itself is short, or there is inelastic tendon, or the sheath is short, or there is adhesions between tendon and sheath. Or you can have acquired cases where you have inflammation of the tendon, inflammation of trochlea in inflammatory, systemic inflammatory conditions, or local inflammation like myositis, cysticercosis, or trauma. Treatment, non-surgical steroids can be tried in inflammatory conditions but may not work well in congenital conditions. And if the deviation is small, the prism correction itself may suffice. Indications for surgery primarily remains primary position hypotropia. So if there is no vertical deviation in primary position, we may not touch the patient. And of course, a cosmetic concern is always there, and if there is loss of binocularity and threat to vision. So the primary treatment remains weakening of superior oblique, which is different from the routine weakening of superior oblique, which we do for comitant strabismus. Here we have to lengthen the superior oblique by doing the expansion procedure, which can be done either with the silicone expander or non-absorbable sutures, also known as chicken suture by NABS. You can do a loop tenotomy. That means you have to put the non-absorbable sutures at the insertion. It has its own complications in form of granulomas, extrusion of the band, or adhesions at the local site, and may lead to iatrogenic superior oblique palsy, for which one has to be very, very careful. So this is a superior oblique lengthening procedure. So you can see you have to do a tight FDT. So here we are lengthening the superior oblique at its insertion instead of in between the tendon. So it helps in a way that it's a relatively simpler procedure as compared to the chicken suture, which we put in between the tendon. The another one is, I'm sorry, I think, yeah. So here we have to do the lengthening procedure in between the tendon, and the advantage that it provides over the insertion lengthening is that you can maintain the fan shaped insertion of the superior oblique, and therefore has less disturbance as compared to the insertion lengthening. So as I said, this is a right eye Brown syndrome preoperatively, and after superior oblique lengthening, one can see that there was improvement in deviation as well as improvement in elevation on adduction. Another case of right eye Brown syndrome, where you can see that there was limitation of elevation, and after SO lengthening, which improved to certain extent. You have to kind of keep it in mind that not entire thing can get rectified. You may still have residual vertical misalignment, you may still have residual limitation in elevation in adduction. So you may have a case where you have Brown syndrome in one eye, as in this case, this eye case had a left eye Brown syndrome, but right eye superior oblique palsy. So such kind of scenario can also occur, and you have to keep in mind about it and have to tackle them accordingly. Coming to the Mobius syndrome, it is another kind of CCD where there is basically abducens palsy with difficulty in facial expression due to the involvement of facial nerve also. So basically patient lacks any expression and ocular movements. It is associated with many other systemic abnormalities and also has a genetic basis to it. So for the systemic association, we have this diagnostic criteria CLUFT, which means that the cranial nerve abnormality 6th and 7th in this case. There are lower limb abnormalities like talipes equinovarus, syndactyly or ankylosis. There are upper limb abnormalities like syndactyly, brachydactyly. There can be facial structure abnormalities like microphthalmia, cleft palate or micrognathia. Or there can be thorax abnormalities form of scoliosis, pectoral hypoplasia or breast anomaly. So this is a video just to show that the ocular movements are affected. In this case, you can see that the patient is not able to look in the either direction. So it's a bilateral, generally it is bilateral only, bilateral 6 nerves affected. You can also see that it is associated with 7th nerve palsy in this case. And also lag of ophthalmos there. So there are 3 specific patterns that have been reported. You may have orthotropia in primary position, which has defect in both adduction and abduction and adduction. There can be large angle esotropias where you have primarily a defect in abduction, and there can be a very large exotropia along with absence of convergence. There can be presence of vertical misalignment in around 9 to 10% of cases with involvement of 3rd and 4th nerve. So this is how we need to differentiate Mobius syndrome from the other differentials like DRS, strabismus fixus, abducens nerve palsies and other causes. So as I said that the Mobius syndrome is characterized by limitation of abduction and facial anomalies. So look for the facial facial nerve palsy like lag of ophthalmos, facial deviations, and there will be large angle deviation as compared to DRS, which will relatively have a smaller angle of deviation. So management is basically symptomatic. You have to do whatever you can, but most of the time we may not be able to help patient a lot, and you have to explain that to patient that the expectations are very realistic. Thank you.
Swati, it was wonderful to have that in a small time capsule. So as she was mentioning about the supraoblique surgeries, what are the choices of supraoblique surgeries that people do? How many are doing the chicken neck suture weakening? Okay. And what are the problems you encounter?
For me, I can't exactly measure how much amount of
Weakening you want to do. Yeah. And the other thing is that you are having working in the nasal area, which is a crowded area. So I would prefer to do a temporal approach. Even for Ken Wright's spacer also, he always suggested putting that thing, but from the temporal approach. So you have to be doing the surgery from the temporal approach. So here, what I generally try to do is the temporal looped in anatomy. So weakening the lateral rectus, as she was mentioning, the lengthening of the superior oblique at the insertion. So that is probably more, productive. People say that you lose the fan of the superior oblique, but here it's a Brown's plus. There is a superior oblique is having overaction. So I say you need to weaken this superior oblique, and the posterior fibers are more important in causing the problem. So you don't mind losing a fan if you have an AC. Okay, so I think we have several procedures on the superior oblique, and here like these are the ones. And in this, I would again like to say, don't do stenectomies, because for Brown's, people have done superior oblique stenectomies, and have landed into superior oblique palsies. So it's like the cure is worse than the problem. So don't do that. Do a controlled procedure of the superior oblique. So this is the various procedures which we have, I think, talked about. What's more in strabismus surgery? Recently, I think we have heard about supraoblique tendon sheath stripping for Browns. Welles has described that. Supraoblique anterior fibers resection for tightening the supraoblique. They say that rather than doing the advancement, you can do a resection. That's Holmes procedure. A muscle transplantation has been talked about, not one which I am very fond of. Anterior tenectomy of supraoblique. And also one procedure which I'd like to talk to in order to say don't do is Sinski's procedure for nystagmus. So these are the things which are there. If there are any other questions, we have maybe a few minutes before we have a photo session. But before we have a photo session of all panelists, please come in. I would like to have a photo of all of you with us in this. So let the panelists stand here.